Everything is
Sir,
fine.
good evening.
Chanakya, Dr. Zaul Haq is going to join or he has some
sir.
challenges?
Sir, no, sir. JL sir joined, sir.
Yes. Good evening, sir. Good evening to all. I have joined now.
Good evening, Dr. Haq.
Good evening, good evening.
Thank you, sir. Good evening, sir.
Good evening. Good evening.
We'll wait for 3 minutes, sir. 3 minutes to go, just 7.
Ali sir, we can start now, sir.
Yeah, Ashu. Am I audible, Ashu?
Yes, sir. It has been made available.
Yes, sir. We are on live. Right.
With due permission, sir, Devashish, shall I start, sir?
Sure.
Yes, sir. Good evening, sir. On behalf of Alkem Laboratories, India's 5th largest pharmaceutical company, I, Ahmad Ali, welcome our eminent doctors who have joined us for today's panel discussion titled as Views on Vildagliptin. At Alkem, it has always been our endeavor to partner with healthcare professionals, and we will continue to do so even in these challenging times. To help us navigate through the meetings, we have with us today an eminent personality, Dr. Devashish Gupta, who will be our moderator for today's panel discussion. We take this opportunity to welcome moderator of the day, Dr. Devashish Gupta.
Thank you.
Dr. Devashish Gupta is one of the leading physicians from Burla, Sambalpur, and is well-known personality in Odisha. He is having a long association with MCL Hospital. He had done several workshops for the benefit of patient education and patient care. I would like to introduce the galaxy of panelists also. Dr. Sudhir Ranjan Samal, a leading physician and diabetologist from Raurkela. He is having more than 19 years of experience. He believes in healthcare that is based on their personal commitment to meet patient needs with compassion and care. Dr. Atanu Thakur, he is among the one of the finest physicians from the Sambalpur, and he is known for offering excellent patient care Currently, he is working as assistant profession in Bimsar, Bulla. Dr. Ziaul Haq, a leading internal medicine specialist from Jharsuguda, is having more than 10 years experience in diabetologists and physician also, well-known physicians in Jharsuguda. Now, I would like to invite Dr. Devashish Gupta to set the context for webinar. Over to Dr. Devashish.
Good evening to all, and a very good evening to my fellow panelists on this discussion, Dr. Atanu Thakur, Dr. Ziaul Haq, and Dr. S.R. Samal from Rourkela. I thank Alkem for giving this opportunity to me to discuss something today on vildagliptin. And to start this discussion on vildagliptin, actually, what is the need to give a combination therapy right from the beginning, as against the standard of care, which is laid down in different algorithms of ADA, EASD, and other bodies. So we'll be discussing today those particular points which are relevant in the context of vildagliptin, its combination, and its use in CKD, its use in the elderly people. And I will also welcome my fellow panelists to add their views and their observations about this particular molecule. So the first point to be discussed in today's clinical discussion is, given the progressive nature of the newly diagnosed type 2 diabetes, how do you view a combination therapy as a strategy in optimization of early diabetes management in the background of the verified trial? So here I would like to remind the viewers and to refresh their memories that a trial was done in UK long back, which goes by the name of UK-PDS trial, United Kingdom Prospective Diabetic Study Trial, which was a landmark randomized multicentric trial on glycemic therapies. It was a long trial which was done over 20 years, from 1997 to 2007, from 1977 to 1997 for 20 years. And the number of patients who were enrolled were 5,102 patients, and they were all newly diagnosed type 2 diabetes mellitus patients. It was conducted in 23 centers across the United Kingdom. And it was observed that by reducing the HbA1c from 7.9% to 7%, the benefits which were obtained was that was a 12% reduction in any diabetes-related endpoint. There was a 25% reduction in microvascular disease, and there was a 16% reduction in myocardial infarction, particularly with the use of oral sulfonylureas or insulin. So long back, around say 24 years back, it was discovered that by reducing the HbA1c, we could get these benefits from it, from microvascular and macrovascular complications. There was a UGDP fear was there. The university group diabetic program had a fear that the use of oral sulfonylurea and insulin for intensive management of hyperglycemia would be harmful to the body. But that fear was allayed by this particular trial, the UK-PDS trial. Although there was a risk of hypoglycemia and weight gain with oral sulfonylureas and insulin, but overall the quality of life was quite improved in this as a result of what was found in this particular trial. In another part of this trial, the embedded study, in which 1,148 hypertensive patients were also included, and they were assigned to ACE inhibitors or beta blockers, it was further found that after a period of 8.4 years, both microvascular and macrovascular disease were also reduced to quite a large extent. So the UK-PDS trial suggested that intensive control of blood glucose right from the beginning gives you a very good result in the long run as far as microvascular and macrovascular disease complications of diabetes are concerned. So with this in the background, the findings of the UKPDF study in the background, with vildagliptin, which was one of the first DPP-4 inhibitor which came into the market, or it was launched, the first DPP-4 inhibitor which was launched was vildagliptin. And this trial, the verified trial, was done to ascertain that whether a monotherapy is better or a combination therapy is better, to be given right at the outset of the disease to get a better outcome. So this verified trial of vildagliptin, the full form is vildagliptin efficacy in combination with metformin for early treatment of diabetes. This was the most compelling evidence, and this trial was continued over 5 years. The enrollment of this trial was started in the month of March, 30th March 2012, and the trial the enrollment was continued up to April 10, 2014. 2 years were spent in enrolling the patient. In this, 4,524 patients were screened, over 254 centers in 34 countries. So it was a very, very broad trial over a lot of countries, and a lot of patients were used. And there were two groups. One was the early combination group. 998 patients were enrolled in that early combination group. And there was an initial metformin monotherapy group in which 1,001 patients were included. So there were two groups basically. One is the early combination group and one is the initial metformin monotherapy group. And this trial was completed over 5 years, and 1,598 patients they completed this trial, out of which 811 were in the early combination group and 787 were the initial metformin monotherapy group. The age group of the patients was from 18 to 70 years. The duration of the disease was 2 years before enrollment. The HbA1c range was from 6.5 to 7.5%. The BMI ranged from 22 to 40 kg per meter square. And 2 weeks screening was done for 3 weeks on only metformin patients. And what was the aim of the treatment? The aim of the diabetes treatment is to improve the quality of life, to prevent chronic complications, and to prevent early mortality. So this is the verified trial in which they used vildagliptin along with metformin. One group was using only metformin and the other group was using a combination of vildagliptin with metformin. So as a result, at the end of this trial, it was found that early combination treatment of vildagliptin with metformin significantly reduced the probability of initial treatment failure, the time to the second treatment failure, and the time to treatment failure compared with monotherapy. So now we come to the point number 2 to be discussed in today's discussion, that is vildagliptin and combinations. So the question is, how do you see vildagliptin as a worthwhile add-on treatment option to metformin or sulfonylurea with the metformin or insulin or SGLT2 in patients who have inadequate glycemic control? Now, the progressive nature of diabetes demands treatment intensification to achieve sustained glycemic control. We have already seen that monotherapy is not very useful in preventing the long-term complications of diabetes. So we should go into a combination therapy right from the beginning to get a good outcome in patients in the microvascular and macrovascular complications are concerned. So this was the point, whether vildagliptin in combination or other drugs, other anti-diabetics in combination have a better outcome. And this was seen in the EDGE study. Now, what is the EDGE study? EDGE study. The full form is effectiveness of diabetes control with vildagliptin and vildagliptin with metformin in type 2 diabetes mellitus. So this EDGE study, this is a real life study. And this real life study is better than randomized clinical trials because a real life study is needed to confirm the clinically relevant findings in RCTs. And this is a real life study which was done in Europe. It was conducted in Europe across a number of countries. And in this, almost 23,000 persons were enrolled, and mostly they were receiving metformin. So the total intended to treat were 22,073 patients, of which vildagliptin was being used in 15,582 patients, and other oral anti-diabetic drugs were being used in 6,491 patients. So the mean baseline HbA1c was 7.9 plus minus 1.3%. The mean type 2 diabetes duration was 6.3 plus minus 5.6 years. The number of males were about 52%. The prevalence of risk factors was quite high. Almost 68.5% had hypertension, 50% had lipid disorders, 9.6% had microvascular complication, and 18% had macrovascular complications. And these patients who were on vildagliptin were almost younger, and they had a slightly higher BMI, and both primary and secondary endpoints were reached more often in the vildagliptin group. Now, what were the primary endpoints? The primary composite endpoint was a drop in HbA1c more than 0.3% as compared to the baseline, without pedal edema, hypoglycemia, adverse gastrointestinal event, or weight gain more than 5% in a year. That was the primary composite endpoint. And the secondary composite endpoint was attainment of HbA1c less than 7% at 1 year, without hypoglycemia or weight gain more than 3%. So it was seen in the vildagliptin group, most of the persons were able to reach the primary and secondary endpoints, composite endpoints, more as compared to the other anti-diabetic groups. And the adverse effects were seen almost same in both the groups, that is about 5 to 8%. Hypoglycemia was lower in the vildagliptin group, 0.2% as compared to 0.8% in the other anti-diabetic group. So in a conclusion, this EDGE trial demonstrated that in a real life setting, vildagliptin as a second OAD can lower the HbA1c to target without well-recognized OADs with side effects and more frequently than the comparative OADs. In addition, the EDGE trial also showed that conducting large-scale prospective real-life studies poses challenges but yields valuable clinical information complementary to the RCTs. So this our second point of discussion in today's topic, which is that vildagliptin with combination. So we see that the EDGE study done in Europe has quite well in a proper way showed that vildagliptin scores over other oral anti-diabetic drugs as far as the outcomes are concerned of the RCTs. And vildagliptin's efficacy when administered in addition to metformin, either as first or second line treatment, improves glycemic control in type 2 diabetes patients and seems to have a favorable effect on the beta cell function. Vildagliptin also improves glycemic control in patients with type 2 diabetes mellitus inadequately controlled with metformin plus glimepiride combination. And the addition of vildagliptin was well tolerated with low risk of hypoglycemia and weight gain. Further, vildagliptin as an add-on therapy to insulin improves glycemic control without increasing risk of hypoglycemia. Now, another very interesting combination is the combination of SGLT2 inhibitor plus DPP4 inhibitor. This is being tried nowadays after the introduction of the SGLT2 inhibitors into the armamentarium of diabetes, and this is a very promising combination, which in the future is going to really give us very good results. So it has been seen in certain studies that the combination of SGLT2 inhibitor plus DPP4 inhibitor has the potential to produce a robust reduction in the HbA1c. This combination is particularly appealing in the light of recent findings that glucosuria produced by SGLT2 inhibitor is associated with an increase in the rate of endogenous glucose production. Now, because SGLT2 inhibitor exert their effect by blocking the glucose to transport at the glomerular level, and thereby they increase the rate of glucosuria, it was found that there is more of endogenous glucose production in such patients. So if we add a DPP4 inhibitor to such patients, it offsets the glucose lowering effect which is induced by the SGLT2 inhibitor by almost 50%. So as DPP4 inhibitor inhibit glucagon secretion and reduce EGP, one can speculate that a combination of DPP4 inhibitor plus SGLT2 inhibitor would prevent the increase in endogenous glucose production following by only SGLT2 inhibitor, and it would produce an additive, even synergistic effect to reduce the HbA1c. And in some studies, it has been found that the incidence of genital infections, which is more with SGLT2 inhibitors, somehow it decreases when we add a DPP4 inhibitor. Probably the DPP4 inhibitors, they inhibit the DPP4 enzyme in the fungi which are instrumental in producing this genital infections, and thereby they reduce the incidence of genital infections. So they will be having a very additive and synergistic effect when used in combination with vildagliptin. So at the end of this point number 2, we see that vildagliptin in combination with other oral antidiabetic drugs shows a better clinical effect, and with SGLT2 inhibitors also it shows a promising synergistic and very good effect which will be of use in the future. Now, the point number 3 of today's discussion is in type 2 diabetes mellitus patients with reduced renal function, adequate glycemic control is essential to delay the progress of kidney dysfunction, but they are at a greater risk of experiencing hypoglycemic events, especially with longer acting sulfonylureas. So how would you assess the role of vildagliptin in CKD patients? It's a very, very important point to be discussed because most of the patients of CKD and diabetes, progressively there is more and more of kidney dysfunction, and giving drugs to control the glycemia in such patients is very risky because of the risk of hypoglycemia and causing more and more damage to the kidney. So we should be very careful in treating such patients with drugs, and it has been seen that giving oral sulfonylureas can be deleterious in such patients. So what is the role of vildagliptin in such patients? So maintaining a good glycemic control in patients with varying degree of CKD to slow down the loss of kidney function is a very important issue in type 2 diabetes patients. And vildagliptin is in the uniquely vulnerable elderly population, that is, who are more than 75 years of age, who have moderate or severe renal insufficiency, many of whom have almost been treated with insulin. The main finding is that vildagliptin was efficacious as compared to placebo, despite a marked improvement of glycemic control. So vildagliptin was found to be safe in patients who had a GFR of about up to 50 ml per minute. It could be given in the proper dose of 50 milligram BID, but from moderate to severe, the dose of vildagliptin has to be reduced to 50 milligram per day instead of the usual 50 milligram BID dose. And most of the people, they fare quite well. The hypoglycemic episodes which are expected are not that high when we use vildagliptin, and it can be safely used in type 2 diabetes patients who have varying degrees of renal impairment, and it can also be used safely in the elderly people. The next part of this clinical discussion, point number 4, is older patients have excess of type 2 diabetes mellitus related morbidity and mortality. So the outcome was that in the main finding of the present pooled analysis of the efficacy and safety of vildagliptin are that this DPP4 inhibitor it is both effective and well tolerated in the elderly patients with type 2 diabetes mellitus. The elderly population with type 2 diabetes poses a unique treatment challenges and have not been particularly well represented in clinical trials. highlighting the need for additional studies to better define appropriate glucose targets and to ascertain the best strategies for achieving and maintaining appropriate glycemic levels. Because vildagliptin does not expose patients to hypoglycemic risk, it seems particularly suited to oral therapy of type 2 diabetes in the elderly. So the conclusion is, as the probability of hypoglycemia with vildagliptin is less, it seems particularly suited to oral therapy of type 2 diabetes in the elderly. Finally, we come to the last point of this clinical discussion, that is with the evidence-based gliptin, vildagliptin, which has now gone off patent, the generic variants have flooded the market, resulting in a sharp drop in the price. So how would you view the expanded role of economical and evidence-based vildagliptin in the spectrum of type 2 diabetes management? So with the drug vildagliptin's patent expiry, the per day cost of therapy has dropped from 45 to 50 per day to 10 to 12 rupees per day, that is almost 1/4, which has marked a shift to a more affordable treatment. Earlier, we were very apprehensive of starting this gliptins in our patients because we knew that they would not be able to continue the treatment due to the high cost. But now we can get the drug at a very, very affordable cost. And as we have seen that it is a very robust drug, which has got pleiotropic benefits, which can be given safely in renal compromised patients, which can be given safely in elderly patient, which can be given safely in combination with other OADs. So it will be a real help and a real boon for most of the poor or lower middle class patients as far as the treatment is concerned. And now the cost of treatment with the gliptin has dropped from 16,000 rupees per year to almost 4,400 rupees per year, making it 1/3 of the original cost. So the conclusion is that as the drug has gone off patent, vildagliptin has resulted in a more affordable diabetes care to millions of diabetics in India, and we will be able to provide a very good drug at a very affordable price, which will be quite useful. And we have seen using vildagliptin for the last more than 10 years, using gliptins in particular for the last 10 to 14 years. These are quite stable drugs. They produce a very good HbA1c reduction. They have got very, very few adverse effects, and they maintain the reduced HbA1c level for a pretty long period of time. So this is my observation that vildagliptin post patent is a very useful drug which can be used by all of us physicians, and it will be very beneficial to the general patients in overall. So with this, after discussing the 5 points which have been given to us by Alkem, I would like to invite my panelists to express their opinion or give their advice, whatever is there. Thank you.
Yes, in my own practice, and this vildagliptin has been a very good to the poor patients as well as to all the Indian patients. As said by Dr. Gupta, there is a quite good saving also, and lowest incidence of hypoglycemia has been also experienced by the patients, which we used to experience with other sulfonylureas or other drugs. Even the efficacy of the insulin has been increased with low dose of insulin is required, and it is beneficial for the elderly where the hypoglycemia is a very common incident, as well as for the CKD cases also. We have found it to be a good option.
Thank you, Dr. Samal, for your interaction and your experience.
Thank you, Dr. Gupta, for a very elaborate, comprehensive description on this neo DPP4 inhibitor. In fact, from the first point itself, with the initiation of therapy in treatment-naive patients of early diabetes, that's the parameters they included in the verified trial, is the initial diabetes patients with a HbA1c of 6.4 to 7.5 they took for the observation. And as for the consensus of EASD ADA guidelines, the one point is pertinent that we should be in a combination of therapy to initiate with different mechanism of actions that will complement each other more in reducing the HbA1c and have a better HbA1c outcome. So as for the EQPD trials and the verified trials, they included the metformin along with vildagliptin, and they found that the treatment failure group were less, and the target HbA1c of less than 7 target were achieved more a percentage of patients in verified trial with a combination of metformin and vildagliptin. So as for the EQPD trial outcomes, definitely the combination therapy with the different mechanism of actions of 2 drugs with the treatment-naive patients of early diabetes will have a better long-term diabetes control and lesser long-term complication as far as the micro and macrovascular complications are concerned. The second point is the patients with elderly treatment with elderly patients and patients with renal failure. There was a article published in Diabetic Care somewhere in the early 20s that the vildagliptin molecule is comparable to the other gliptins, DPP-4 inhibitor, as far as the renal safety profile is concerned. The hypoglycemia event, even if with the eGFR of less than 60, were less with vildagliptin, and that is comparable to sitagliptin also. Just we need to modify the doses accordingly. And in elderly patients, basically, this is a point of concern as far as the hypoglycemia part is concerned. And in this publications, they found out that there was no nocturnal hypoglycemia associated with vildagliptin, and the overall hypoglycemic episodes were only 0.4%. So it is very minuscule compared to other OHA like the sulfonylureas and the other OHs. The other point that that comes into mind as far as choosing a OHA is the CVOT outcome, the cardiovascular outcome. So with this study, also it is a phase 4 trial study with a lot of patients, and they found out that the CHF incidence, that is more with the pioglitazones and other sulfonylureas, were less often evident with the DPP-4 inhibitors, specifically with vildagliptin. And there is a matter of concern regarding the DPP-4 inhibitor that is less often though, but initial it was a point of discussion regarding the pancreatitis. And mostly it was studies with sitagliptin, and they found out that even if you give experimental animals of 200 times dose of vildagliptin, the pancreatic incidents were very few. No, of course. So that is a major advantage with respect to other gliptins. Regarding the elderly, there are several factors that we take into account as far as choosing a OHA is the incidence of dizziness, infections, and nasopharyngitis, specifically with nasopharyngitis. And with that study also is a phase 4 trial study published in Diabetic Care. They found out that these incidents were very, very less. And weight loss, where they found out with certain individuals, elderly patients, that they could not make out the mechanism pertaining to the weight loss. And it was found out this is not related to gastric offset or GI adverse effect. But the mechanisms, they yet to find out why there is a little bit of weight loss in elderly patients in long-term vildagliptin. So this is not a point of concern, as there is no weight gain at source. But that should be looked into for a long-term study as far as this the point of sarcopenia is concerned in elderly. So, and there is no other associated treatment adverse effect outcome with the other molecule that normally we use with diabetes long term is the ACE inhibitor. ACE inhibitor, as this is the PK kinetics of vildagliptin is non-cytochrome P450 enzymes mediated. So there is very little interaction with other co-administered drug and specifically with ACE inhibitor, and the incidence of angioedema is very, very less, and it is self-limiting. That is comparable to other OHA along with the ACE inhibitors. So this is summarize that already you have discussed, Dr. Gupta, and comprehensively regarding the better aspect of this molecule, and summarizing this is a very good molecule, DPP-4 inhibitors for add-on therapy, for early diabetic control, and to prevent the long-term therapy, a safe drug, and it will certainly reduce the long-term macro and microvascular complications as far as the diabetes complications are concerned, and also safe in renal failure and also in elderly.
Thank you, Dr. Thakur, for enlightening us on few points. That is the interaction of anti-diabetics with antihypertensive like ACE inhibitors, because it is not metabolized. It is, although it is metabolized in the liver, but the cytochrome system is not involved in the metabolism of vildagliptin. So in that way, it has got very few interactions with other drugs, and it can be given very safely. And your point which you have taken on different aspects are also very, very welcome. I would just like to mention here about the comparison of vildagliptin and sitagliptin, both of which were almost launched at the same time, 2007 to be sure, to be precise. And a very small study was done, that is the J Victoria study. J Victoria study was done in Japan on 20 patients who were given vildagliptin and sitagliptin, or vice versa, and they were admitted, and they were continuous glucose monitoring was done in these patients. And in this continuous glucose monitoring, it was found that giving sitagliptin 50 milligram daily results in 70% suppression of the DPP-4 inhibitor enzyme over 24 hours, while vildagliptin 50 milligram twice a day gives 80% or more suppression of the DPP-4 enzyme over 24 hours. And to the different mode of binding, it was found that there is a greater reduction of the blood glucose levels with supper and breakfast with vildagliptin as compared to sitagliptin. Also, it has got a improvement of the mean amplitude of glycemic excursion, that is MAGE, and it reduces the oxidative stress, vildagliptin. So there are less of adverse cardiovascular effects in the long term. So somehow, due to these 2 or 3 additional effects, vildagliptin scores over sitagliptin as far as the glycemic excursions are concerned and the cardiovascular safety profile is concerned. Now I'll request Dr. Ziaul Haq to add something on today's discussion.
Good evening to all, sir. As Dr. Gupta and Dr. Tanu Thakur both of have spoken very well about vildagliptin, and almost they have covered most of the points. And I do agree with both of you that apart from metformin, vildagliptin is a very good add-on drug. And in fact, in Japanese Diabetes Society, they have also talked about DPP-4 inhibitors being the first-line drug. If they are not starting metformin, you can start with DPP-4 inhibitors also. And as we know that one of the drugs from Japan, Takeda Pharma, is very popular in India because of its low cost. And after this, this patency is over for vildagliptin. Now vildagliptin also has become very cheap drug in India, and it can be very safely prescribed in our type 2 diabetes patients. And apart from metformin, I also believe that vildagliptin has got very good safety profile, and it can be added on with metformin. Regarding its renal and cardiovascular safety, both of you have already discussed about these things. That renal safety is very good till 50, till GFR is 50 to 60. It can be given in full dose, and once it goes less than GFR 60, we have to reduce the dose to half. In any condition, it does not cause any kidney damage, but because there will be overdoses of the drug in the body as the GFR reduces, we have to reduce the dose of the drug. But it can be given to very low GFR also, but we have to reduce the dose accordingly. As we all know that regarding heart, there is very low glycemic variability with vildagliptin. So when there is, as we were discussing just now, when the MAGE is low, there will be less this cardiovascular morbidity with use of vildagliptin there. So there also it scores very well. In elderly there will be low risk of hypoglycemia. In fact, vildagliptin and all DPP-4 inhibitors, which are vildagliptin and this GLP-1 agonist, as both these drugs, drug groups are incretin mimetics, and they basically work after taking food, means they reduce the glucose which increases after taking the meal. So they are very good in reducing the prandial sugar. So there is very less hypoglycemia with use of these two drugs. Also, they are weight neutral. In fact, GLP-1 agonists are reducing weight also, and DPP-4 inhibitors not as much as GLP-1 inhibitor agonists, but they are also helping in reducing the weight. So in elderly and overweight, and to prevent hypoglycemic episodes, all this this group is very useful. I think I'll conclude with this now. Any other thing we'll discuss later.
Thank you, Dr. Hark. Thank you so much for your valuable additions to today's talk. Some few points I would also like to add. In Europe, they recommend that if the SGOT, SGPT levels are more than 3 times of the maximum upper levels, then it should not be used. Although its safety has been found in hepatic impairment, it can be used in hepatic impairment because it does not interfere with the cytochrome system. But still, they recommend that if the SGOT, SGPT levels are more than 3 times of the upper normal limit, it should not be used. Anyway, but it is a very safe drug which can be used in all these things. And
even
again,
in hepatic impairment, yes.
It has been found to reduce small, dense LDL particles, and also it reduces the albuminuria. So in that way, it has also got additional cardiovascular safety profile. So all in all, if we consider this molecule vildagliptin with the strength of the verified trial, with the strength of the J Victoria trial, with the strength of the interval study of elderly with the CKD on vildagliptin, and a Gallant study also done on CKD study with vildagliptin, with the strength of all these trials, with the data which has come from all these trials and all these studies, with the reduction in the price due to the off-patency of the drug, and the safety in as far as hypoglycemia and weight gain and other things are concerned, this drug has got a very, very nice future, and it has already been used for a long time in India. And the combination with SGLT2 inhibitors is definitely a very interesting combination, and we'll have to see in the future what different trials come up. So with this, and I also thank all my panelists who were so helpful in adding and giving their valuable points and suggestions for today's this clinical discussion. And now I hand over to Mr. Ali to give his concluding remarks.
Thank you very much, sir. Thank you very much for wonderful discussion, sir. Sir, we have recently launched one product, first time in the world, once daily vildagliptin from Alkem, Gluvilda OD, 100 milligram sustained release tablet. And if you see the bioequivalent to the innovator brand 50 mg BID, and Gluvilda OD has 84% DPP-4 inhibitor over 24 hours with the vildagliptin SR at par with the innovator brand 50 mg BID. So recently launched with a very affordable price, sir, just 10 rupees per tablet. So I would like to thank We take this opportunity to thank Dr. Devashish Gupta for moderating the panel discussion, and all the panelists, Dr. Sudhir Ranjan Samal, Dr. Ziaul Haq, and Dr. A. Thakur, who have joined us and all the panelists for views on vildagliptin for clinical practice. We'd also thank all the doctors who have joined us for the panel discussion, and I'm sure you will appreciate the views on vildagliptin presented today. We at Alkem Laboratories will continue to serve doctors and patients by making our products available, especially our chronic products like Gluvilda M, Gluvilda OD, Jupiros, and Olchem. Thank you for a wonderful discussion, sir. Good night.
Thank you all.
Thanks.
Good
Thank you
night.
so
Thank you,
much.
sir. Sir, thank you, sir.